Right. Good morning and welcome to the Department of Medicine grand rounds in this wintry morning. We're excited today to have three of our highly accomplished senior PGY3 residents to speak to us about the topic that's of interest to them, and it's going to be of interest to many of us who attend and practice medicine, and practice medicine. We're going to speak about geriatric cardiology, a booming field. We have today Dr. Mercedes Lupo, who's a third-year resident going to chief at the Geriatric next block, and she's unfortunately leaving us to Toronto after that to do geriatric medicine next year. Then we have Dr. Klement Yeung. Dr. Yeung is a PGY3 chiefing at St. Joe's right now. And he's going to, as well, head to Toronto to do his nephrology residence fellowship after that. And Magdalene Au, and Magdalene is chiefing right now at the Geriatric, and following that, she will head next year to do cardiology at Toronto as well. We're losing all of them, but maybe we can recruit them after that to come back and practice geriatric cardiology when they come here. I will stop here and pass it on to Dr. Au to kick us off.
Okay. Thank you so much for that introduction. My name is Mercedes, and I'm joined by Klement and Magdalene today to talk about the field of geriatric cardiology. We're seeing a significant increase in Canadian adults over the age of 65, and in particular, adults over the age of 85, who are one of the fastest growing population segments. This increase in longevity brings with it increasing complexity and the need to acknowledge the distinct needs of this growing population of older adults. So today we wanted to talk about this in the context of cardiovascular medicine. We'd like to begin by acknowledging that we meet on the traditional territories of the Mississauga and Haudenosaunee nations, and within the lands protected by the Dish with One Spoon Wampum Agreement. Our objectives for today are to present an overview of the geriatric syndromes, to discuss a little bit about the cardiovascular changes with aging, to look at geriatric syndromes and their intersection with cardiovascular medicine, to look at the clinical and scholarly developments as an overview of geriatric cardiology, and then more specifically to delve into ACS in older adults and aortic stenosis and TAVI in older adults. So we'll start off by framing this talk with a case. This is not an uncommon case to most on the internal medicine service, though there are clear problems and potential solutions from a cardiovascular medicine perspective. Looking at this with a geriatric lens, the case only begins to unfold and exemplifies many of the concepts we're going to highlight today. So we have an 85-year-old woman from home with a background history of mild Alzheimer's dementia, hypertension, dyslipidemia, and CKD, who presents to the emergency department in a CHF exacerbation thought to be secondary to known severe aortic stenosis. She's accompanied by her daughter, who lives close by to her. So the burning question is what to do with her aortic stenosis, but the other layers to this include the polypharmacy. She can easily be on 5 or more medications with her comorbidities. Her functional status, for a diagnosis of dementia, there has to be some amount of functional limitation. So what impact does that have on her presentation and her management? Cognition, she likely has probably some capacity for decision-making, but she is at higher risk of developing delirium in hospital, as well as the presence or absence of other geriatric syndromes like frailty, incontinence, malnutrition, for example, that would give pause when considering management options. And then you think about what recovery from something like a TAVI procedure might look like. You think about what social supports she may have to help in her recovery as well. So before we get into the cardiovascular side of things, I thought I'd set the stage by highlighting what are known as the geriatric syndromes, which you can keep in mind as we discuss cardiovascular disease in older adults. So these are health conditions that are common in older adults that don't fit necessarily into specific organ-based categories and are often multifactorial in etiology. So things like falls, frailty, malnutrition, incontinence, polypharmacy, and so on. A comprehensive geriatric assessment will cover these areas and identify possible multi-component non-pharmacological and pharmacological interventions. But you can see how these geriatric syndromes common in many of our older patients, add a level of complexity to clinical presentations, investigation, and management, as well as discharge planning. As we age, there are physiological changes that take place in the cardiovascular system that predispose older adults to cardiovascular disease. From a vascular perspective, over time, there's arterial wall thickening and endothelial dysfunction, which reduce nitric oxide activity, overall interfering with the vasculature's ability to dilate. So ultimately, there's less capacity to upregulate blood flow in response to myocardial demand. This predisposes older adults to type 2 MIs and NSTEMIs. And further, chronic low-grade inflammation, which is associated with many age-related diseases like arthritis and diabetes, but also the geriatric syndrome of frailty, contributes to subclinical and overt coronary artery disease. Over time, there's LV wall thickening and subsequent decline in diastolic function. From a conduction standpoint, there's a loss of number and function of SA node pacemaker cells and increase in the conduction abnormalities in the context of fibrosis and hypertrophy, which develop over time. From a valvular perspective, the processes leading to atherosclerosis and ischemia similarly lead to valvular disease, such as aortic stenosis and secondary MR, which are most common in older adults. And it's important to note as well that these changes may also coincide with changes in the renal system, including renal artery atherosclerosis, decreased cortical volume, and nephrosclerosis, all of which can complicate, again, the presentation, investigation, and management of cardiovascular disease in older adults. Now that we've reviewed what is meant by geriatric syndromes and some of the cardiovascular changes that we see with aging, we can think about how those syndromes and cardiovascular disease can intersect and what that means for our clinical practice. At presentation, geriatric syndromes such as cognitive changes, polypharmacy, and multimorbidity can impact our understanding of the presentation of cardiovascular disease. From a cognition standpoint, for example, depending on the level of cognitive impairment, the patient may or may not be able to accurately describe symptoms in a way that would suggest one diagnosis over another. This cognitive impairment may impair the ability to disclose past medical history as well, though fortunately we have electronic patient records that can help with this. As well, cognitive impairment may interfere with the ability to appropriately take medication, which may contribute to cardiovascular presentations. So, for example, someone who has difficulty taking dual antiplatelet, post-PCI leading to restenosis, or not taking a diuretic. Polypharmacy is common among older adults as well and increases the risk of drug-drug interactions, which may be pertinent to the presentation. Medication burden as well is associated with this and may lead to difficulties in taking medications, which may contribute to presentation. From a multimorbidity standpoint, underlying conditions may influence how a patient experiences symptoms. For example, a patient's chest pain may be more attributable to their underlying congestive heart failure than a new ischemic event. Moreover, ACS in general in older adults is more likely to manifest with symptomatology considered non-ischemic. Klement will review this in a little bit more detail in his section of the presentation, but in the Silver AMI study of more than 3,000 patients over the age of 75 with an acute MI, 44% of patients did not report chest pain as a primary symptom, including 40% of those patients presenting STEMI. And women in particular are less likely to report chest pain as the main symptom, oftentimes reporting things like nausea and abdominal pain. With respect to investigations, a couple of examples include the impact of delirium and multimorbidity again. So from delirium standpoint, a hyperactive delirium, for example, may interfere with the patient's ability to undergo particular tests, which is something that many of us have encountered. Sometimes this leads to the use of sedatives, which allow for test completion, but may worsen the patient's delirium. Delirium is a very important geriatric syndrome to consider as it leads to downstream cognitive and functional decline, reduced quality of life, and decreased likelihood of returning to home after discharge. From a multimorbidity point of view, investigations like troponin biomarkers or ECGs may have baseline abnormalities that make it more difficult to interpret acute changes, which is where access to previous studies is helpful in relying on patterns rather than absolute numbers in some cases. Apologies, the light just went off. Troponins have reduced specificity in older adults due to underlying renal disease, replacement cardiac fibrosis, or hypertension, for example. And older adults are more likely to have baseline ECG changes. So, for example, 20% may have underlying LVH, 10% may have underlying conduction abnormalities, and this can influence interpretation and limit certain stress tests that are available. Aside from the interpretation of testing, one needs to consider multimorbidity when considering the safety of tests. So older adults may have an element of CKD or other reasons for volume depletion that pose a risk of acute renal injury with investigations like coronary angiograms. And then when it comes to deciding on management, there are lots of geriatric syndromes to consider. If we take polypharmacy, for example, you can imagine how when a patient presents with a cardiovascular acute presentation, they can easily be started on 2 to 4 new medications, depending on the course of their stay, which can put them at that polypharmacy level, increasing the opportunity for drug-to-drug interactions and falls. This is then compounded by age-associated changes in pharmacokinetics and dynamics. Or if we talk about falls, if medications have antihypertensive effects, there is further risk of falls. Additionally, much of the hospital practices, especially around acute cardiac presentations, lead to bed rest, immobility, tether use that contribute to functional decline in hospital and further risk of falls in the future. From a cognition standpoint, when determining medical therapy, capability of adhering to medication should be considered and polypills prescribed when possible. From a geriatric lens, one considers how the patient takes their medications and what social supports they may have to be able to do this at home. Further, having a degree of underlying cognitive impairment puts the patient at increased risk of hospital delirium, leading to outcomes that we described previously. This is where delirium prevention strategies are especially important. Underlying cognitive impairment, depending on how severe, also has implications for capacity for decision-making, oftentimes requiring a surrogate decision-maker to be available. From a frailty standpoint, one must consider the risk versus benefit of critical care measures and invasive procedures for managing acute cardiovascular presentations. Meg will be talking about this a little bit more later on when we discuss the management of aortic stenosis. The role of physiotherapy and cardiac rehab are especially important, which again, Klement will be touching on later on in this presentation. With multimorbidity, there is possibility of potential dysynchronous care from multiple specialists. As well, it becomes important to understand where patients are in their trajectory of their comorbidities when considering those risks and benefits of more aggressive and life-prolonging measures and having those nuanced discussions. Ultimately, when deciding management from the geriatric lens, it's important to remember that older adults are a heterogeneous population and that it's critical to ask what matters most, which is one of the 5 M's of geriatric medicine. This means asking about the importance of outcomes beyond traditional cardiovascular outcomes, things like quality of life, the ability to live independently, and the ability to return to previous lifestyle and environment. Clinical practice guidelines are not always helpful to reconcile this because most are disease specific and older adults may often have multiple disease processes ongoing. Over the years, there have been developments in the research field of geriatric cardiology from the landmark Framingham Heart Study, which began in 1947, the cardiovascular study in 1989, to the Canadian Cardiovascular Society Consensus Conference in 2002, and multiple subsequent publications shown here and what we'll discuss further in our presentation. We've developed a wealth of scientific information on physiology of aging, risk factors for cardiovascular disease in older adults, and clinical course and prognosis. We now have fellowships in geriatric cardiology for clinical and research training to further the work in this field. Ultimately, however, I think we still need more research to encompass that multi-comorbidity, the heterogeneity of older adults from a cognitive, functional, and social standpoint, and more data exploring those important outcomes for older adults. The Canadian Journal of Cardiology in 2016 published a paper which outlines a framework for clinical practice in the area of geriatric cardiology. So in clinical practice, the geriatric cardiology assessment involves a comprehensive geriatric assessment looking at multiple geriatric syndromes, cardiovascular history, careful medication assessment to identify potential harmful drug interactions, as well as the practicalities of how they are taking their medications, a psychosocial assessment to understand the patient's family and social supports, the use of assisted devices and coping strategies, and ultimately the patient's care preferences. It's a collaborative process amongst geriatricians, cardiologists, internists, as well as pharmacists, physiotherapists, occupational therapists, dietitians, and ultimately with patients and their care partners. I will leave the floor to Klement now to talk us about ACS.
Perfect. Thank you, Mercedes, for that overview. So I'm going to be talking about some of the aspects of managing acute coronary syndromes in the elderly. And obviously, this is a huge topic, so I just selected a few areas that I wanted to highlight. So first, why is this topic important? So let me talk about some data about frailty and outcomes for patients with ACS. So this data is from a few years ago now, but Graham et al. Conducted a study where they looked at patients admitted to the cardiology inpatient unit at the University of Alberta Hospital with a diagnosis of ACS. They stratified patients into different groups based on an assessment of frailty, based on domains such as cognitive impairment, dependence for activities of daily living, burden of illness, and several other categories. And so a higher score corresponds with increased frailty. So looking at the table describing patient characteristics, I wanted to draw your attention to several areas. Patients with higher scores were older and more likely to have a history of hypertension, previous MI, congestive heart failure, and chronic kidney disease. And higher scores were also importantly associated with a longer mean hospital length of stay. It's also interesting to note that there were some differences between groups regarding the type of revascularization treatment undertaken, though that was only statistically significant in cardiac cath as well as PCI and not in CABG. They also conducted a survival analysis, and this figure presents the Kaplan-Meier curve for survival to 5 years of follow-up after hospitalization for ACS. And as we can see, those that were deemed more frail had worse survival over this time frame. Now, moving on, here is some more local data. This is a graph showing the proportions of the population in each age group in 2022. And if we run the numbers, just under 20% of the Canadian population is 65 years and older. Now, this graph shows the incidence of ischemic heart disease and acute MI in men and women in each age group. And as we can see, in both men and women, the rates of both diagnoses of ischemic heart disease as well as acute MI increase with age. This is another graph showing similar results with prevalence of acute MI increasing as age increases in both men and women as well. So now we know that ischemic heart disease and acute MI are more common in the older population. The older population tends to be more frail, and frailty is associated with worse outcomes. So what do the guidelines say about this? The CCS guidelines don't make any formal recommendations about therapy in the older adults, but they do recognize that frail patients are more likely than non-frail patients to have adverse outcomes. They do suggest routine frailty and comorbidity screening to improve risk assessment and allow more informed decision-making. In the American guidelines, they do make a specific recommendation that in patients greater than 75 years old who have chest pain with accompanying symptoms such as shortness of breath, syncope, acute delirium, or unexplained fall, to consider ACS as a diagnosis. As mentioned before, as a patient ages, a multitude of factors, including autonomic neuropathy, injury to cardiac sensory afferent nerves due to past ischemic disease, cortical failure from cerebrovascular or other central nervous system disease, extensive comorbidity, higher pain thresholds, and pre-existing mental status abnormalities contribute to a higher rate of atypical presentations and unrecognized acute MI. The elderly also frequently present with complications of acute MI rather than the actual symptoms of the acute ischemic event. For example, elderly patients presenting with new onset unexplained congestive heart failure should be screened for acute ischemia. They also have a recommendation saying that in older patients, as in all patients, the treatment for coronary artery disease should be based on an individual patient's preferences, cognitive function, and life expectancy. In the European guidelines, there are also a few recommendations for the older adult. As you can see here, they recommend to apply the same diagnostic and interventional strategies in older patients as for younger patients. And they also have a formal recommendation for choice and dosing of, for the choice and dosing of antithrombotic therapy and secondary prevention to be adapted to renal function. So what are the changes in the older adult that we should keep in mind with medical therapy? With aging, multiple physiological changes affect both the pharmacokinetics and pharmacodynamics of many medications used for ACS. Older adults can exhibit reductions in kidney function, hepatic blood flow, and muscle mass, with an increase in body fat that in turn affects the absorption, distribution, metabolism, and elimination of certain medical therapies. These changes greatly affect the pharmacokinetics of orally administered medications that must dissolve to be absorbed by the gut, then undergo first-pass hepatic metabolism before entering the systemic circulation, and then potentially be renally eliminated. For IV medications, first-pass metabolism is bypassed, but protein binding and elimination of the medication can be altered. Furthermore, low body weight and lean mass are common in many older adults with ACS, which can affect medication dosing to avoid adverse events. From a pharmacodynamic perspective, adaptive and structural vascular and myocardial changes attributable to aging can lead to exaggerated responses to certain medications. For example, diminished carotid sinus baroreceptor sensitivity and a slowing of the sinus node activity and AV conduction can increase the risk of bradycardia with medications such as beta blockers, calcium channel blockers, and amiodarone. Furthermore, with an increase in arterial and ventricular stiffness, older adults may become preload sensitive, leading to a greater risk of hemodynamic lability from vasodilator therapies and diuretics. So, medical therapy for ACS in the older adults in general is similar to that in younger patients, but needs to take into consideration the increased atherothrombotic risk and higher bleeding risk compared to younger patients in the context of the physiological changes that were previously explored, as well as prevalent geriatric syndromes. That being said, risk versus benefit assessments tailored to each individual will help guide the use and dosing of ACS therapies. Therapies initiated in the hospital should be evaluated on a recurring basis during outpatient follow-up, with escalation of treatment as needed to reduce overall cardiovascular risk, but also de-escalation or deprescribing as needed to relieve or prevent side effects in the context of patient goals and preferences. So in the Canadian guidelines, the current recommendation for patients who undergo PCI for NSTEMI or STEMI is dual antiplatelet therapy with aspirin 81 milligrams once daily, plus ticagrelor 90 milligrams POBID, or prasugrel 10 milligrams once daily, which are preferred over clopidogrel 75 milligrams once daily. They do acknowledge that advanced age is a risk factor for increased bleeding risk, but don't make any specific recommendations in that population. And so let's look at some data comparing clopidogrel versus ticagrelor or prasugrel. So one of the newer trials, though now a few years old, the Popular Age trial conducted by Gimbel et al., was a trial where clopidogrel was compared with ticagrelor or prasugrel in patients aged 70 or older with non-ST elevation ACS. So essentially, eligible participants were randomly assigned in a 1-to-1 ratio to receive clopidogrel or ticagrelor or prasugrel on top of standard care. And this was open label, so patients and treating physicians were aware of the allocated treatment strategy. And there were two primary outcomes that they looked at. The first was a bleeding outcome consisting of any bleeding requiring medical intervention, defined as Plato major or minor bleeding. And the second primary outcome was the net clinical benefit of all-cause death, MI, stroke, and Plato major or minor bleeding. So this is the table of baseline characteristics. So 1,002 patients were randomly assigned to clopidogrel or to ticagrelor or prasugrel. And I will note that in the ticagrelor or prasugrel group, 95% patients were prescribed ticagrelor. But overall, you can see here that the baseline characteristics were fairly well balanced between both treatment groups. Before we dive into the results, I will mention that during follow-up, premature discontinuation or switching of the study drug did occur in 47% of the patients randomized to ticagrelor or prasugrel, as compared with 22% of those randomized to clopidogrel. And this study did employ an intention to treat analysis strategy. So on the left, the primary bleeding outcome, consisting of Plato major or minor bleeding after 12 months, occurred significantly less often in the clopidogrel group than in the ticagrelor group, 18% versus 24%. And on the right, for the composite net clinical benefit outcome, occurred in 28% of patients receiving clopidogrel versus 32% of patients receiving ticagrelor. So the clopidogrel strategy met the criteria for non-inferiority, but not for superiority. So these results suggest that for older patients, especially at increased risk of bleeding, clopidogrel may be considered for first choice therapy due to decreased risk of bleeding and similar efficacy. That being said, further trials will be required to change guidelines regarding antiplatelet therapy in older patients. There was also a networked meta-analysis of over 14,000 patients comparing clopidogrel, prasugrel, and ticagrelor in older patients with ACS that was conducted, which also showed that clopidogrel has the most, or suggests that clopidogrel has the most favorable profile for reducing bleeding events, but suggests that prasugrel and ticagrelor may have a more favorable anti-ischemic profile. I don't know whether in the older population who are at high risk of both thrombosis and bleeding, whether there will come a time where we will routinely switch P2Y12 inhibitors at some point in their course of therapy based on these concepts. But I don't believe that there's enough data for that at present. Here are some other medications often used in the setting of ACS. So beta blockers may be of particular benefit because of their anti-ischemic effects and influence on the burden of arrhythmia in the setting of MI. But cautious dosing is warranted because while monitoring for bradycardia and heart failure in the acute setting, and you have to watch for chronotropic incompetence and fatigue during chronic management. Lipid-lowering therapy reduces cardiovascular disease events, but we need to watch for side effects such as myalgias, which may impact a patient's mobility, quality of life, and independence. Furthermore, we need to be cognizant of potential drug-drug interactions with these medications. We also often use drugs that target the RAS system, which have been associated with mortality benefit in patients. The older population, however, is often more vulnerable from a renal and hemodynamic standpoint, which may impact utilization of these medications. I'm noting that I'm not really going to be talking about invasive strategies today, but we'll briefly say that for the management of STEMI in older adults, it follows the same general principles as for younger patients. The indication for primary PCI in older patients presenting with STEMI should consider STEMI-related variables, including delay in presentation, extent of ECG changes, and LV dysfunction, as well as patient-related variables, including severe comorbidity, severe cognitive impairment, and limited life expectancy. Barring these end-stage disease processes, primary PCI is safe and effective even among patients with very advanced age, as long as it's aligned with their preferences of care. For NSTEMI, to date of the 5 randomized trials specifically investigating an invasive strategy in older patients, 4 have found no benefit of invasive treatment on the primary endpoint compared with conservative management, whereas 1 did show that an invasive strategy reduced recurrent MI and urgent repeat revascularization. So although the older adult population is rapidly expanding, these patients, as mentioned before, do not represent a homogeneous group. They differ on the basis of or presence of frailty, comorbidities, physical or functional limitations, and social status when presenting with ACS. Older patients living with a greater burden of geriatric syndromes are more likely to develop disability, loss of independence, and impairment in quality of life and ability to self-care after an ACS event. And when managing older patients presenting with ACS, the goals of care should extend beyond traditional cardiovascular outcomes. And assessment of patient-centric goals and outcomes should have a focus on quality of life outcomes. Next slide, please. Cardiac rehab is a comprehensive secondary prevention cardiovascular disease management program that uses exercise training, behavioral modification, education, and psychosocial counseling to improve outcomes in patients with ACS and other conditions. Cardiac rehab has been demonstrated to reduce recurrent cardiovascular disease events, death, and rehospitalizations, and improve cardiorespiratory fitness. Cardiac rehab is an important component of ACS care for older adults, with benefits applying across the clinical spectrum. Cardiac rehab targets functional enhancement as a key outcome benefit. And for many older adults, this is a vital clinical priority that is not fostered by other aspects of treatment, which reinforces the distinctive value of cardiac rehab. So bottom line from this section is that ischemic heart disease and ACS are more prevalent in the older population. The prevalence of frailty increases with age. Frailty is associated with an increased risk of adverse health outcomes. Important pharmacokinetic and pharmacodynamic changes occur with advancing age, which may impact our use of certain medications. In older adults at high risk of bleeding, consider using clopidogrel as first-line P2Y12 inhibitor due to risk of bleeding. And cardiac rehab, though important for all patients, should be strongly considered in those with advanced age. And I will hand over to Meg.
Thanks, Klement. So for this last section of our presentation, I'll be discussing TAVR as it relates to geriatric assessment as well as outcomes. So aortic stenosis, we know, is a progressive disease that leads to, in its end stage, LV outflow tract obstruction. And the natural course of the disease is that once patients become symptomatic, mortality is at over 50% at 2 years without valve replacement. And to date, we know that there's been no medical therapies that have been shown to change this course of the disease. And so the only option is valve replacement, which, in addition to prolonging life, can help to relieve symptoms, increase exercise capacity, as well as increase quality of life. Up until about the past decade, the only option really was SAVR, so surgical aortic valve replacement. And it wasn't until the past decade that things have been revolutionized by the introduction of TAVR, which have allowed for individuals who would normally be considered too high risk for an intervention to receive an aortic valve intervention. So there's been, over the past decade, 2 series of landmark trials, the partner trials, as well as the core valve and evolute trials, which have provided the evidence base for TAVR. This started with the partner B cohort in 2010, which was published and showed that TAVR was superior to medical therapy in patients that were considered inoperable. Since then, multiple other trials have been published to expand the eligible populations. So we now know that TAVR is not inferior to SAVR with patients who are high risk, as well as intermediate surgical risk. And then most recently in 2019, even patients who are considered low risk. And kind of digging into the TAVR evidence, not really the focus of our talk, but I think it's important to just remember who were the patients that were included in this trial. So in the partner B trial, the mean age of patients, 83. Symptomatic, obviously, 92% were at NYHA class 3 and 4, but also these patients were quite comorbid. Coronary artery disease present in 67%, cerebral vascular disease in 27%, COPD in 41%, with 21% being on home oxygen, and 42% with pulmonary hypertension. And this landmark trial showed that TAVI had decreased all-cause mortality as well as decreased rehospitalization compared to standard therapy. It did show, however, with TAVI that there's an increased risk of TIA and stroke, which is related to the procedure itself and kind of the embolic showering of debris that happens with the procedure. In the bottom right, you can see that not only were there more patients surviving at 1 year, but those that did survive had less symptoms. So they were more likely to be at NYHA class 1 or 2. I think it's still important to note, though, that you can see that even among those who receive a TAVR at 1 year, mortality rate was still quite high at the 1 year mark, which kind of raises the point that patient selection is very important for TAVR. This is kind of one schematic, one representation of decision-making when it comes to TAVR. It really starts with patient goals and preferences, and then an estimation of what's the anticipated benefit. And that's done with simultaneous clinical risk stratification as well as geriatric risk stratification. And who's doing this? It's a multidisciplinary heart valve team, which includes cardiology, cardiac surgery, allied health, internists, as well as geriatricians. And ultimately, we can come out of this decision-making either identifying TAVR being beneficial, being futile, or sometimes it remains uncertain and clinical judgment is required. So now I'll focus more on the geriatric TAVR assessment itself as it relates to different geriatric syndromes. First, looking at frailty as well as the concept of nutrition closely tied together, the impact of mood and cognition, and lastly, what matters most. So starting with frailty and nutrition. So as Mercedes and Klement have discussed, frailty is an important prognostic factor when it comes to geriatric cardiology. Frailty provides important prognostic information in addition to the traditional risk scores such as STS that might be used in procedural situations. The prevalence of frailty is quite high among patients undergoing TAVR. So depending on which frailty score is used, it can range from 26 to 68% of patients. And we know that frailty is a major risk factor for morbidity and mortality after TAVR, increases the risk of one-year mortality as well as worse quality of life at the one-year mark. The Frailty AVR trial is probably the study is probably the largest study to date in the field of geriatric cardiology as it relates to TAVR. This was a prospective multi-center cohort study that was done between 2012 and 2017 and was led out of Montreal. It involved just over 1,000 patients with a median age of 82 years. And the primary study was really a comparison between different frailty scales. And what they found was that the essential frailty tool set, which was this brief 4-item scale, outperformed all the other frailty scales. It was the strongest predictor of mortality at 1 year, as well as the strongest predictor of worsening disability at 1 year among patients who underwent TAVR. This is the EFT you can see on the right, and the 4 items. One is a measure of lower extremity weakness, one of cognition, one of pre-procedural anemia, as well as albumin. And that allows you to generate an EFT score, as well as the associated 1-year mortality with TAVR. And this tool set is the one that's recommended by the Canadian Cardiovascular Society during the TAVR pre-procedural assessment. Nutrition is closely tied with frailty. And in a pre-specified analysis of the Frailty AVR, they did look at the impact of pre-procedural nutrition on outcomes. And what they found was that poor pre-procedural nutritional status was associated with a higher 1-year mortality. How did they screen for malnutrition? They used this tool called the Mini Nutritional Assessment Short Form. Again, it's a very short tool, 7 items, which makes it attractive to use practically, clinically. And it had an 85% sensitivity for detecting malnutrition in patients who are undergoing cardiac surgery. So now that we know that frailty and malnutrition are prognostic and associated with worse outcomes after TAVR, the next question becomes, what can we do about that? Is there a way that we can defrail individuals and optimize them before they undergo their procedure? So these are some ongoing trials that are looking at exactly that. So there's the Perform TAVR trial, which is an upcoming randomized trial that will be evaluating an intervention that includes both nutritional supplementation before TAVR as well as a home-based exercise program after TAVR. There's also the TAVR Prehab trial, which will be looking at the impact of 8 to 12 visits to physical therapy prior to TAVR. So we'll be looking for the results of these studies. Next, I'll be looking at the impact of mood and cognition. Again, this is a sub-study of the Frailty AVR cohort study, looking at mood specifically. And what they found was that patients who had baseline depression had higher mortality at the 1-year mark. And they also looked at this concept of persistent depression. So looking at patients who had depression even 6 months after their procedure, and that was associated with a 3-fold increase in mortality at the 1-year mark. So mood is a very important thing to consider prior to patients receiving their TAVR. It also raises the question, after patients get their TAVR, will their mood improve? You'd think that if their symptoms improve and their quality of life improves, that their mood might improve as well. And this is an area that still requires further study. There are some small observational studies out there that suggest maybe improvement. For example, this is a prospective cohort study of just over 200 patients who underwent TAVR in Germany. And what they found was that among patients with baseline depression, there was an improvement in their depression symptoms at 6 weeks, 6 months, and 12 months. But again, there's still more work to be done in this area. In terms of cognitive impairment as a risk factor, this has also been studied. So this was a large retrospective cohort study in the US, 57,000 patients. 5% of which had a diagnosis of dementia at the time of TAVR. And what they found was that individuals with cognitive impairment were more likely after their TAVR to have a longer hospital stay, more likely to be discharged to a rehab facility, and more likely to have in-hospital delirium, as well as bleeding requiring transfusions. So poor cognition before the procedure associated with poor outcomes after the procedure. Interesting to note, however, that cognition can also be potentially improved with the TAVR procedure. So this is a meta-analysis of 20 studies looking at cognitive changes after TAVI. And this meta-analysis found that cognitive decline was experienced by about 7% of patients, but about 19% of patients experienced some degree of cognitive improvement. And the kind of physiological theoretical explanation is that with TAVR intervention, you're improving cerebral autoregulation, and that might also help to improve cognition. I did also just want to touch on the topic of cerebral embolization and stroke after TAVI. So we know from studies that new ischemic lesions in patients is very common for patients undergoing TAVR. Over 70% of patients after TAVR would have new lesions on imaging. And again, this is thought to be due to that embolic showering that happens during the procedure. But really only a minority of these lesions seem to become clinically apparent. That stroke is only observed in 2.3% of patients and delirium in 14.5% of patients after TAVR. A meta-analysis recently looked at the impact of what they called the silent brain infarcts after TAVI. And what they found was that the higher number of silent brain infarcts was associated with a greater incidence of postoperative cognitive dysfunction. Overall, though, we don't completely understand yet what is the clinical significance of these new ischemic lesions. Delirium after TAVR is also an important complication of the procedure to consider. Based on meta-analyses, the pooled incidence ranges from 8 to 23% after procedure, and it's associated with longer hospital stay, higher risk of readmission, higher mortality at 1 and 3 years. And importantly, these patients often do not improve in their functional status or return to their functional baseline. In terms of risk factors for delirium after TAVR, this can be divided into predisposing factors, which would generally be considered non-modifiable, as well as precipitating factors, which are potentially modifiable. This study found that the strongest risk factors were carotid artery disease, cognitive impairment or previous delirium, as well as AKI. So how can we prevent and treat delirium after TAVR? It really looks the same as how we would manage and treat delirium for patients undergoing other procedures, or even just patients that we see on the internal medicine ward. And a lot of the prevention has to do with non-pharmacological measures. So lastly, I want to touch on what matters most, which Mercedes had highlighted previously. So coming back to this decision-making schematic, a lot of what I've talked about is the decision to go with TAVR. But for some patients, the decision can be that TAVR is futile, or that the decision is just not to undergo TAVR. This was an interesting study that was done. It was a retrospective cohort study done out of a US private not-for-profit health system, looking in a contemporary area why patients with symptomatic severe aortic stenosis did not undergo aortic valve replacement. And on reviewing of these patient records, 65% of them would have been considered appropriate candidates for AVR. And the most commonly cited reason for not undergoing AVR was patient or family refusal at 40%, followed by some kind of critical illness not due to aortic stenosis at 28%. And there was also a certain population, 8%, where the symptoms could not clearly be tied to the aortic stenosis, and there was some uncertainty there. In internal medicine, we're often the ones who might be making that diagnosis of severe aortic stenosis, and being that first point of discussion with the patient and family, whether or not that they would want this to be further worked up for referral to cardiology, for referral to a valve team. And there are some decision aids out there for patients and families that can help to guide that decision. This is an excerpt from a resource from CardioSmart, which is created by the American College of Cardiology. And they have great decision aids out there for TAVR versus SAVR, as well as TAVR versus symptom management, which breaks down the decision into simple, plain language and has graphics that can help to explain things. So here they have a graphical representation of some of the outcomes after TAVR. The Canadian Cardiovascular Society suggests this mnemonic to help identify patients for whom TAVR might be futile. So patients with advanced dementia, who are bedbound and not mobile, who have cachexia or severe sarcopenia, who have disability for all or most ADLs, and who have end-stage organ dysfunction. For patients who are not undergoing TAVR, there still needs to be a care plan in place. This is a schematic from a paper that advocates for early involvement of palliative care specialists in patients who are diagnosed with severe aortic stenosis. And in fact, they advocate for involvement of palliative care as early as the time of diagnosis and alongside the workup and decision-making process. So not necessarily just when the decision is for no TAVR. And they list a few reasons why palliative care might be helpful even in the decision-making process. So for example, if patients are having difficulty defining their values, goals, and preferences, if assistance is needed to elicit the patient's understanding of their prognosis and treatment in the context of their multimorbidity, and if there's disagreement among stakeholders, so among patients, caregivers, families, and heart team members about goals of care. So overall, early involvement of palliative care can be quite helpful in making these decisions. So in terms of the overview of this section, so geriatric perspectives can provide valuable insight to help identify patients who might benefit most from TAVR and supporting those who choose medical therapy. And really, we do need further research to identify and assess interventions that can help to optimize geriatric risk factors peri-procedurally. What we hope our take-home messages are for this presentation. We hope that you recognize that geriatric cardiology is a growing field of clinical and scholarly work. And it's a field that recognizes the impact that geriatric syndromes can have on the diagnosis and management of cardiovascular disease. That multidisciplinary teams are really important in helping to navigate the complexities of geriatric cardiology. And really, we do need further work to best understand how to manage cardiovascular disease in older adults. That takes us to the end of our presentation. Thank you all for listening.
Thank you very much, Dr. Au, Dr. Yeung, and Dr. Lupo for this excellent grand rounds. And it's like very, very relative to our practices. I believe Dr. Gernstein has put in, so if you have a question, please put it either in the Q&A or raise your hand, and I will bring you in to ask your question in person. I'll start with Herzl. I'm assuming you want to speak up your question. So Herzl, you're in.
Yeah, you can hear me okay?
Yeah, you're good, Herzl. Go ahead.
Great. Guys, thank you very much for a very comprehensive presentation. And I think in my mind, there's actually two really important points that I get out of this. And I think that is important to stress for everybody. One of them is that what's important is frailty and comorbidity, not age. And it's really amazing how much ageism is rife within many of our colleagues. And I just want to remind everybody that virtually all of the cardiovascular prevention trials and most of our evidence is based on randomized controlled trials done in people aged between about 62 and 75. And many people would consider those the elderly, but that's where all of our evidence base comes from. So when we're talking about, what do we know works? What do we know doesn't work? It's based on people who some people would consider elderly or older, so, and have more than one risk factor. So I think it's really important that we're not talking about these people when we're talking about things. We're talking about individual assessments of comorbidities and frailty and other things. And I would even ignore the age in a lot of people. And it's really important. And that's my comment. My question is for the TAVR story. I don't think you mentioned, but I'm sure people have done studies of things like, at the time of TAVR, anticoagulating them beforehand, or using some way of reducing the risk of emboli from the fractured valve and stuff. Have those been successful or unsuccessful? I just don't know that literature.
Yeah, that's a great question. In terms of the anti-thrombotics, that wasn't an area that we necessarily focused on as much. So I'm sure that the work is out there. I'm not sure right now what the current evidence is. In terms of the second part of that, the embolic showering that you mentioned, yes, that there is a lot of work right now in terms of different devices to try to minimize that. There was a recent meta-analysis that showed that these devices can decrease the amount of showering, but then there appears to be still ischemic lesions that appear on imaging. So there's still some work there to be done to better understand why that is.
Thank you, Herzl, for your comments, and Dr. Au for your responses. There's in the comments, I see that it looks like Dr. Sabrina Keane and Dr. Demers are working towards a geriatric cardiology fellowship at McMaster, which is a fantastic move, and we know how important is that. I'm going to bring in Dr. Holbrook to ask her question in person. And go ahead.
Thank you very much. I'm just following up a bit on Herzl. So this is a great area. These are patients that we see all the time. But I just wanted to correct one misconception. And there's a small group of faculty who have a special interest in this area because we're rapidly approaching the age group ourselves where this is going to be, critically important. But there is a widespread misconception that medications themselves change with aging, the impact of medications. All of the evidence that we have suggests that that's not the case, and maybe best described with statins. So basically, this notion that pharmacokinetics change significantly, pharmacodynamics change significantly, once you correct for the disease state and the polypharmacy, and one physiologic marker does matter for some drugs, that's renal function, and that's for drugs that are only renally cleared. Beyond that, you really cannot show that there is a significant difference. So it's a bit along the lines of what Dr. Gerstein was saying, is age is just a number. It's more the physiology, the comorbidity, and the polypharmacy that's important. And when it's been able to be looked at, that's been shown time and again. Thank you.
Thank you, Anne. So important comments. I have also Dr. Kernu has a question, and I'll bring Craig. You're on.
Oh, thank you so much for your presentation. And one of the things that you mentioned is sarcopenia of aging, and the average muscle mass is between 30 to 50% between the ages of 30 and 70. and we're seeing so many patients have so many comorbidities, and it's hard for every specialist to look beyond what they can do. And I like your initial trial about partner, where it looked at, inoperable patients, mortality of 60 versus 40% at 2 years. Unfortunately, we need better tools or to say to a patient, how much quality time do I have left, and how much more quality time will I have if you give me a procedure? And I find that's very hard to sort out. I'll echo what Ann Holbrook was saying, is that, myalgia, it's not even clear that statins actually cause myalgia, but we blame statins for do that. That's a whole separate issue. Myopathy is a very rare disease. It's muscle weakness, not predominantly pain. So we deprive people of a lot of preventive strategies. If you want to use a lower dose of statin, add ezetimibe to medium dose of statin therapy. For antiplatelets, we're switching to Plavix as a single agent long term, and then after procedures, 1 to 3 months of dual antiplatelet therapy may be all that you need. And we know that over the age of 75, and you can, at some sort of biologic age, you bleed more. So there's lots of things you can do differently. But the biggest impact is that so many people are going for procedures. You're weak and dizzy, so the family doctor will do a carotid ultrasound. My feet are sore. You'll do peripheral vascular disease assessment. But it's basically frailty that's taking away people's lives, and they haven't exercised in 10, 15 years. And doing a procedure, they're going to probably not start exercising. So can you give us some tools to help us decide when we see a patient, is that what is the best frailty index? I think these visual analog scores that look pretty impressive. Is that the best way of doing it? You mentioned the one for the TAVI, that short one that looked really nice as well. But it'd be nice if we can all agree on a tool or two to determine frailty. And no matter what you do, what's your prognosis? So do you think this tool you have over here is the best one for every patient for frailty? Is that the best we should be looking at?
I think that's a great question, and it's a complex syndrome that we're trying to assess, and maybe necessarily not always having like all the time that we would want to make such a comprehensive assessment, which is why tools like this might be attractive. This is the one that they've studied in TAVR, and I'm sure that they've looked at this as well in other contexts in ACS or other conditions. I don't know whether or not this is the best one in every context, but I agree that, trying to come up with, ways to help to kind of get a global sense of how a patient will do based on frailty rather than age is important. And sometimes that might involve getting the opinion of geriatric colleagues as well to get that kind of global assessment.
I agree with Meg, and I think this actually has been used as well with cabbage assessments, if I'm remembering correctly. But I think for whatever scale is used, for it to be effective, it has to be something that people are going to be able to use easily and efficiently in their practice. So this presents a pretty simple way to do that, to allow it to be applied to multiple settings. And I think we need more research looking at the effectiveness of this tool versus maybe some other tools in multiple different settings. And just acknowledging, again, some of the important outcomes for older adults and why it might be important to look at frailty specifically.
That's great. Thank you very much. I don't see more questions. There's a couple of comments. I just want to say, this is great. An important shift in, there are actual questions, but anyway, we don't unfortunately have time to take more questions. We're at time, but I want to just focus that this is really great focus on a shift in paradigm. It's not about age, it's about what matters to patients, about the patient function, nutrition, frailty. These are key important ones. And I really appreciate your plug-in. And I know Dr. Marison has put in a comment. Sorry, Dr. Morwood has put in a comment, the plug-in for palliative care, but also all of us have to learn how those skills of identifying the patient's goals and focusing on their comfort if we cannot provide an intervention. I'm sure our speakers are going to be available to answer those questions that are left, but we'll have to let people move on with their day. So really appreciate you guys bringing this important topic to conversation today. And thank you very much for your presentation on this comprehensive topic. And thank you, everyone, and have a great day.
Thank you.
Thank you.